Hello, my name is Jorge Castillo, and I'm the Clinical Director of the Waldenstrom's Program at the Dana-Farber Cancer Institute. Today, I've been invited by the organizers of the conference to talk to you about what is the best frontline treatment for patients with Waldenstrom's macroglobulinemia. As with every presentation that I do, my email address is right there on the bottom. If you have any specific questions about a case or you like a slide, please feel free to reach out to me, and I'll be happy to provide information and help as much as I can. So I always start my presentations with the man, Dr. Waldenstrom's. He's a Swedish physician who was very prolific. He described many different conditions, from hematological issues to autoimmune conditions to rheumatological issues. So this is a case report that he presented in 1944, describing two patients with coagulopathy, hyperviscosity, and a very large protein in the serum called hyperglobulinemia, as he called it. And again, 75 years later, we understand this disease, I think, a little bit better. And I think he will be proud of what we have learned over time. Now, we understand that this is a lymphoma. We understand that this large molecule is what we call IgM. And these patients can present with hyperviscosity, coagulopathy, severe anemia, and a bone marrow biopsy findings that are not precisely myeloma, as he called it, incipient myelomatosis, but rather a lymphomatose process. So when a patient comes to see me, before I recommend any treatment, I want to make sure that the patient actually has Waldenstrom's. And at this time in my clinic, I make this diagnosis using three specific criteria. Number one is having a lymphoplasmacytic lymphoma, a B-cell, small cell lymphoma with plasmacytic differentiation in the bone marrow. We can find in other places as well, lymph nodes and other places, but the bone marrow is almost universally affected and involved in patients with Waldenstrom's. The second criterion is the presence of a serum IgM monoclonal protein. Again, some patients with lymphoplasmacytic lymphoma can have also secretion of IgG, IgA, free light chains, or even be non-secretory, but over 90% of the patients would have IgM secretion. Therefore, all the Waldenstrom's macroglobulinemia patients are lymphoplasmacytic lymphomas, but not all the lymphoplasmacytic lymphomas are actually Waldenstrom's. Regardless, the patients with IgG and IgA lymphoplasmacytic lymphoma should be managed very similar to how Waldenstrom's is. So everything I'm going to be mentioned today applies also for non-IgM LPL cases. The last addition to the criteria was the detection of the MYD88 mutation. This is a mutation that had been described initially in aggressive lymphomas, but over 90% of patients with Waldenstrom's have this mutation, as we will see later. And in my mind, if a patient comes to see us with these three criteria put together, I think the likelihood that a patient has Waldenstrom's is over 99%. Now, Waldenstrom's can manifest in many different ways, and again, a portion of patients will be essentially asymptomatic, and asymptomatic patients should not be treated. I think that's a very good initial message. However, Waldenstrom's can manifest in many different ways. We do have anemia being still the most common reason why we need to treat patients with Waldenstrom's. I think over 2/3 of the patients would need to be treated because of anemia and causing fatigue and tiredness and issues like that. We do have about 15% of patients presenting with hyperviscosity, nosebleeds, headaches, retinal bleeds. Usually with IgM starts around 3,000 and really more concerning when it's over 6,000. We do have patients with neuropathy, which typically is distal, sensory, progresses over years, affects the toes first, and have some demyelinating features in the nerve conduction studies. But also patients can have cold agglutinin disease, they can have cryoglobulin disease, they can have amyloidosis, they can have lymphadenopathy or hepatosplenomegaly. Pleural effusions are very rare, 1% to 2% of the cases that we have in our database. Renal involvement even, which is much more common with myeloma, but rare with lymphoplasmacytic lymphoma, 2% to 3% of patients. And even meningitis because of Waldenstrom's called Bing-Neal syndrome, which affects about 1% of our patients. As you can see, the clinical features of Waldenstrom's are very diverse. However, as I said earlier, we don't treat everybody at diagnosis, and there are many reasons. Number one, Waldenstrom's is incurable. Number two, our treatments not only can cause toxicity, but can also promote resistance. And there is no evidence as of today that treating early actually prolongs patient survival. And patients with Waldenstrom's can enjoy decades of life. The median survival of patients continues improving, and the median is anywhere between 15 and 20 years currently in our clinic. On the right, you can see data from our study that we published last year. This is patients with asymptomatic Waldenstrom's that were followed over time. And as you can see here, of the 439 patients that we studied with, About 30% of patients needed treatment within 2 years of diagnosis, but up to 10 years, about 80% of patients needed to be treated, which means that 1 in 5 patients with Waldenstrom's might not need to be treated for the following decade, which means that if a patient is really asymptomatic, we should give the patients those, the opportunity, I would say, of not necessitating treatment, and therefore treatment should be given only when it's absolutely needed. We can guide our decision based on these guidelines. This was set up, about 15 years ago, almost 20 years ago now. Anemia, symptomatic anemia, thrombocytopenia, symptomatic hyperviscosity, as well as moderate to severe neuropathy, and symptomatic lymphadenopathy, hepatosplenomegaly, renal involvement, effusions, Bing-Neill syndrome. As you can see here, the key is symptomatic. So a patient can have some lymphadenopathy, probably about 2-3 centimeters. It's already pathological, but the patients are asymptomatic. That's probably not a reason to treat. If patient has a very mild neuropathy, not affecting the patient's activities of the daily living or quality of life, that's probably not a reason to treat either. So we need to be very careful about the need of therapy. So I think two things are important here. Number one, the patient needs to be symptomatic, their quality of life needs to be affected. But number two, we need to make sure that the disease is what's causing these problems. If a patient has neuropathic, diabetic neuropathy, for example, I think the worst thing we can do is actually give them treatment for Waldenstrom's. So it's important to work up all these patients' symptoms to understand the relation with the disease whenever we decide to treat these patients. So let's say we get to a point in which a patient is diagnosed properly, is symptomatic, and they need to be treated. So what are the frontline treatment options on these patients? We do have the classic chemoimmunotherapy approaches. We have a number of different chemotherapies that tend to work in this type of patients, and we have alkylating agents, we have nucleoside analogs, and we do have combinations with rituximab specifically. We do have evidence with cyclophosphamide, bendamustine, fludarabine, and cladribine. And as you can see here, the overall response rates are very high, between 70 and 90%, very good response rates between 20, 30, 40%, and progression-free survivals, median progression-free survivals measured between 3 and 6 years. So very effective and with durable responses as well. Now, the issues with chemotherapy are the affectation of the immune system, myelotoxicity, as well as immunotoxicity, risk of infections, and also the risk of potentially of myeloid neoplasms, such as myelodysplasia or acute myeloid leukemia, which is something that we need to have in mind, specifically when we treat young people. Another family of medications are the proteasome inhibitors, and we do have data in Waldenstrom's with bortezomib and carfilzomib, as well as ixazomib. And again, the overall response rates, and all this is frontline, the response rates are very high, and they're between 80 and 90%. Major responses between 60 and 75%, and progression-free survivals, again, between the 4, 5, or 6 years. So the efficacy is very similar to chemotherapy. The side effect profile is very different. No myeloid neoplasms that we have described with any condition, with any of these treatments so far. But bortezomib can give you neuropathy in a substantial number of patients. So we use it subcutaneously once a week to minimize that risk. Ixazomib can have a little bit of neuropathy as well, the risk, and also some gastrointestinal issues. Carfilzomib is associated with some cardiopulmonary toxicity specific in elderly patients. So again, it's important to personalize our recommendations, our treatment recommendations on these patients. For a while, we were recommending maintenance rituximab on patients with Waldenstrom's, and I think this study really helped us understand what the actual role of maintenance is. This is a prospective study run by the German group, in which that was presented at ASH last year, has not been fully published yet. But patients with Waldenstrom's frontline was treated with bendamustine and rituximab, and about half of the patients were assigned to observation only, and the other half was assigned to rituximab to be received once every 2 months for 2 years. And we have here on the right that the progression-free survival, as well as the overall survival curves, did not differ between these two groups. I mean, a couple of important issues with this study is that patients needed to be on a partial response to actually be able to qualify for this study, which means that patients who achieve minor responses, meaning IgM decreases between 25 and 50% only, were not included in this study. So that's something to have in mind. Also, patients who were older than 65 and patients with higher IPSS-WM might have benefited from rituximab maintenance. So I think we should wait for the formal data being published on this study, so we can understand a little bit better what the role of maintenance is in patients with Waldenstrom's at this time. In my clinic, if the patient has a minor response to chemoimmunotherapy, I do still recommend maintenance rituximab. on those patients. Some of the patients have very high IPSS-WM risk. That's something I'd also consider for recommendations of rituximab. Note that rituximab maintenance doesn't have any side effects. There are issues with infusion reactions. There are issues with intolerance to rituximab, as well as late onset neutropenia and risk of infections. So it is also a pros and cons discussion to be had with patients with Waldenstrom's. But as you can see here, it confirms the bendamustine and rituximab efficacy with an overall response rate of over 93%, major responses of 88%, and VGPRs at 25%. Now, how do we move forward with understanding the biology of the disease and how that can help us tailor treatment options? I think the discovery of the MYD88 mutation in 2012 by Dr. Stephen Trion in our group, it was a seminal finding to actually understand the biology of Waldenstrom's. As you can see on the right, we have our initial study on the top, and then we have a list of different centers in Europe and United States and Asia that have actually further validated this finding. And I think at this time it's fairly accepted that the MYD88 mutation defines Waldenstrom's, and over 90% of patients with Waldenstrom's will have a mutation in this gene. The second discovery from our group as well was the detection of CXCR4 mutations. Again, our first study using whole genome sequencing detected about 27% of patients having this mutation, and more recently, up to 40% of patients with the development of PCR testing as well as Sanger sequencing. And again, multiple validations across the country and in Europe and Asia as well. So I would say about a quarter to a third of patients with Waldenstrom's will have CXCR4 mutations. But why is that important? I think it's important because the clinical presentation we found might have something to do, with the genomic features of these patients. And this is research from our group as well as French and Spanish and other European centers. And we have that, if you look at the column in the middle, which are the patients who have also CXCR4 mutations, those are the patients that tend to have more bone marrow involvement. Those are the patients who have more IgM, higher IgM levels, and higher risk of hyperviscosity, as well as acquired von Willebrand's disease. So if you think about these patients, hyperviscosity, coagulopathy, that very much sounds like the patients that Dr. Waldenstrom described. The last column on the right are the patients who do not have MYD88 or CXCR4 mutations, that actually entail about 5 to 10% of the patients. Those patients are more lymphomatous, in presentation. They have more lymphadenopathy, and they actually have a higher risk of transforming to a diffuse large B-cell lymphoma based on our research as well as others. So understanding these pathways of activation for Waldenstrom's survival are very important, and our research showed that BTK is a very important component of the activation pathway of mutant MYD88. And that gave Dr. Trion the idea of running a study on BTK inhibitors in patients with Waldenstrom's driven by this discovery. Interestingly enough, we knew that there was an accessory pathway of activation through CXCR4, which might or might not affect the efficacy of BTK inhibitors on these patients. So BTK inhibitors, specifically ibrutinib, has been already tried in patients with Waldenstrom's. The seminal study on top, 63 patients with 91% overall response rate, 73% major response rate, and a progression-free survival median that has not been reached at 5 years yet. We have also a study on rituximab refractory patients with very similar findings, and actually ibrutinib in primary therapy, in frontline therapy, which is what brings us here together, 100% response rate on those patients with an 83% major response rate and a PFS at 18 months of 92%. So highly efficacious therapy. Now, what is interesting, and this is a paper that just got e-published a couple of days ago in the JCO. This is the long-term follow-up of patients on the seminal study. We do have, again, in the column in the middle, we see how patients with CXCR4 mutations actually had just a lower overall response rate than patients without CXCR4 mutations. Major response rates were also a little bit lower. VGPRs were definitely lower. And even the time to major responses was also more prolonged. So not only the depth of the response and the time to the response seems to be affected by CXCR4 mutations into ibrutinib monotherapy, but also, as you can see on the right, these are the progression-free survival curves. And we can see how the blue continuous line, which is MYD88 only patients, have a 75% 5-year PFS rate, while the patients with CXCR4 mutations, they get into a median PFS at about 4 years and the patients without MYD88 mutations went to a median within 2 years of therapy. In the front line, we saw very similar findings with very rapid, more rapid responses in patients without CXCR4 mutations, and also the depth of the response in terms of the IgM, also more delayed based on this. So we need more follow-up to understand what the PFS is going to look like, and this is going to be followed probably with next year with a more updated manuscript. We do have the ibrutinib plus rituximab study published a couple of years ago. And again, ibrutinib rituximab was compared against rituximab placebo. And again, it's not surprising to see that the depth of the response and the time to response, and as well as the progression-free survival, was better on the combination of rituximab and ibrutinib versus rituximab alone. The major criticism for this study is that there was not ibrutinib-only arm. So I understand that ibrutinib improves rituximab based on this study, but I do not know really what the role of rituximab is to improving ibrutinib on this, and I don't think we have a clear answer for that. For that purpose, I just put this table together in which the ibrutinib rituximab combination data is in one column, and the other 3 ibrutinib monotherapy studies are in 3 other columns, and we can see that the outcomes are not too different. So it's unclear at this time, I would say, if adding rituximab to ibrutinib will make any benefit in terms of response or durability of response. In my clinic, I tend to use the combination of ibrutinib and rituximab, specifically in patients with CXCR4 mutations who are not candidates for a clinical trial. So the current guidelines for the NCCN now recommend bendamustine, bortezomib, ibrutinib, and cyclophosphamide as preferred regimens, but the only category 1 is ibrutinib with and without rituximab, and we have other recommended regimens that includes cladribine and fludarabine and ixazomib and carfilzomib as well. So there are new BTK inhibitors now. Acalabrutinib is up and coming, published just earlier this year. This is twice a day instead of once a day, like ibrutinib is. And major responses are about 80%, with overall responses at 90%, and 2-year progression-free survivals between 80 and 90%. The side effect profiles of BTK inhibitors are very similar in terms of the risk of atrial fibrillation, the risk of bleeding, and the risk of rashes and gastrointestinal issues, as well as cytopenias. And I think there's not too much of a difference between acalabrutinib and ibrutinib. Since this was not a comparative study, it's very difficult to assess that difference. But there's some data in CLL in which patients who are intolerant to ibrutinib can go into acalabrutinib, and at least 2/3 of those patients will not have recurrence of the adverse events that they saw with ibrutinib. The new kid on the block is zanubrutinib. This is a BTK inhibitor coming from China. This is the ASPEN study, recently published as well, in which patients were randomized between zanubrutinib and ibrutinib. This was an open label, and again, the caveats that come with that. The study also was powered to show a difference in VGPR. Even though it's a phase 3 study, the outcome was VGPR rather than progression-free survival. And as you can see on the graphic on the left, zanubrutinib VGPR was 28% versus 19% with ibrutinib. That was considered not statistically significant, and based on that, this was a negative study. Progression-free survival, again, very similar between the two groups, but the risk of atrial fibrillation is lower with zanubrutinib, 15% of ibrutinib versus 2% with zanubrutinib. Also, the risk of neutropenia is higher with zanubrutinib than with ibrutinib. So again, another layer of personalization that we could use when we counsel our patients to receive therapy. At Dana-Farber, we genotype every patient for MYD88 and CXCR4, and again, that is something that we can do in academic centers. And if the patient does only have MYD88 mutation, BTK inhibitors remain our preferred option for therapy. If the patient had no MYD88 or CXCR4, those patients are less likely to benefit from BTK inhibitors, and chemotherapy and proteasome inhibitor-based therapy makes sense on those patients. In the patients who have CXCR4 mutations, then we need to see if the patient needs a rapid response or not, and we can use BTK inhibitors with rituximab, but also bendamustine rituximab or cyclophosphamide or proteasome inhibitors are reasonable in that setting as well. Ongoing clinical trials, we do have venetoclax, the BCL2 inhibitor, coming up, very interesting. This is data presented last year at the myeloma workshop. As you can see on the left, the waterfall figures show a 90% efficacy rate with us at 75% major response rate and 25% VGPR rates. And it doesn't seem that CXCR4 mutation status actually affect the response. And we have an 18-month progression-free survival of about 80%, which is very encouraging, specifically because half of these patients were previously exposed to BTK inhibitors. So based on that, we're actually combining ibrutinib and venetoclax now in the previously untreated patients. This is a study that is ongoing. We have enrolled about 10 patients in this study that will include about 50 patients, and we'll be publishing on this or presenting this later on. This is a rapid list of all the different clinical trials available currently with BTK inhibitors and PI3 kinase inhibitors, CXCR4 agents, HCK inhibitors, and anti-CD38 antibodies in patients with Waldenström's. So the future looks very bright in terms of treatment options for patients with Waldenström's microglioma. And with that, I want to thank you for your attention.